Ladies and gentlemen, distinguished guests, it's my pleasure to introduce the next session, which is called Follow the Data, Building Better Data Systems for Health. My name is Kelly Henning, and I lead the public health programs at Bloomberg Philanthropies in New York City. And I'd like to, before I give a bit of an introduction to the session, I would like to introduce our distinguished panelists. First, I have Philip Settle, who's the Vice President and Director of Civil Registration and Vital Statistics in New York City at Vital Strategies. Next, I have Yusuf Murungwa, who's the Director General of the National Institute of Statistics in Rwanda. He's working on evidence for policy. Next, I have Ngo Chapter, who's the Policy Advisor to the Government of Bangladesh's Cabinet Office, who's going to talk about institutional development. And then I have Lola Dare, President of ChestRand, Global Development Initiatives, who brings the Southern perspectives to global health and development efforts. And I have Richard Delaney with me today as well, who's the Deputy Director at Vital Strategies in New York City, who's going to talk about country-level work to leverage data to meet policy objectives. So I'm excited to talk to you a little bit today about some of the programs that we're supporting at Bloomberg Philanthropies, and also more broadly with the panelists about work on data for health. There we go. We've got a little delay. Let's just make sure. On the next slide. I think all of you are very aware of the challenge that faces us, which is worldwide. Half of deaths do not have a death certificate, with a cause of death which leads us to a disconnect between what people die from and how government resources are spent. And this is a big and major issue that we're really all grappling with, including all the panelists here today. And what happens is that governments are often making policy decisions without data at their disposals, and they have to rely very much on outside estimates. And this causes a lot of difficulty, particularly when we have not enough evidence or enough information about causes of death. In addition to that, we have very poor monitoring of risk factors at country level, and policymakers are lacking linkages to the data that can help determine the country's priorities. So you're getting the sense of a theme here, which is very much about helping countries use data most effectively, and that's really what we're all about in this panel. So how do we close those gaps, and what do we do about them? We do notice in our Data for Health program, for example, that we support at Bloomberg Philanthropies, that countries are very interested in this topic area and really have a lot of willingness to take it up. It's a very important issue for us. They also have a lot of interest in technical assistance, which can translate the evidence into action at a population scale. So the idea is to really go broadly with this information and support. We also really like to ensure that the data itself is improved and that existing and new data are linked to policymaking. So no one's interested in data on the shelf, data that's not usable. We really want it to be translated into action, and that's a fundamental piece of the Data for Health program that we're supporting at Bloomberg. And also solutions that are affordable and scalable. So this has to be replicable, and it has to be something that countries can really take on. So the Data for Health strategy, which we've been supporting since 2015, really is about putting countries first and partnering with interested countries. And there are 3 buckets of work, if you will, that have to do with strengthening the collection of birth and death data, also building capacity for public health data to action or to policy, and then finally, testing new solutions for rapid and consistent surveys that can discuss risk factors principally for non-communicable diseases, which is an area that's somewhat lacking. This is just a snapshot, if you can notice the map here, of the 20 countries around the world where we're providing support through the Bloomberg Initiative on data. And I would mention that in China and in India, we're focused currently in Mumbai and Shanghai. We don't have a countrywide initiative at the moment, but we're really seeing a lot of rapid success in those cities. We have partner organizations, some of whom are represented here with us today. They include the US CDC, Johns Hopkins Bloomberg School of Public Health, the University of Melbourne, Vital Strategies, and the World Health Organization. And we're so pleased that we have a funding partner in this effort, which is the Australian government, that has really provided support as well. We have some regional partners, UNECA and UNSCAP, who are critical to putting these pieces of the data program that we're investing in into action at the regional level as well as the country level. So we've had a lot of success. I'm not going to walk through each and every one of these, but just to say that more than 1 billion people are covered in these 20 countries by this initiative that we've been working on. And we're seeing that some of the areas that are of interest, perhaps, are things like verbal autopsy, where 36,000 of these have been performed and completed in the last couple of years. This is an area where there's a lot of interest by countries to get more out-of-hospital death information. We've got many policy briefs that have been developed by governments and are used by governments, and more than 200 people are trained in these NCD mobile phone surveys, which are actually developed and rolling out in 10 countries. So a lot of progress and a lot of excitement on the ground to be working on these data issues around health. So on today's panel, we're going to have a number of presentations. They're going to focus on civil registration and vital statistics and the fact that it's a cornerstone. We're going to have a presentation on the Rwanda experience with data improvements, on the Bangladesh experience with data improvements. We're going to get the Ngo perspective and some discussion about data impact, and then we'll take some questions from the floor, and we're looking forward to that. So let me just walk over to my panelists, and we'll get this started right away. So, Philip?
Thank you. Thanks, Kelly, very much. Can we have the next presentation, please? A few times during the World Data Forum, we have heard a call out for improvements to civil registration and vital statistics, often in partnership with digital identity management. We heard this yesterday in the plenary session about the importance of administrative sources of data and CRVS in relation to the SDGs. Yet we also know that many administrative sources of data are in need of improvement. And I'm going to spend just a few minutes talking about this rhetorical question: are improvements possible? If they weren't possible, I probably wouldn't be here doing a presentation. But I think the important thing to stress is that there's a lot of conventional wisdom about strengthening administrative sources and CRVS systems, some of which I hope you can read on the screen. It's too expensive, the systems are too moribund, they're too complicated, ID will replace civil registration, these sorts of things. But in point of fact, CRVS is not only critical to and central to the Sustainable Development Goals, it's critical to the functioning of modern state systems. And the foresight of the Bloomberg philanthropies in investing in this particular administrative data source is beginning to pay dividends in terms of seeing improvements to the systems and to the data generated, not to mention the benefits that flow directly to the individuals who are registered in terms of their births and the family members of those who registered deaths. This slide just points out that under the Data for Health initiative, we have been active in really emphasizing, in partnership with government, the CRVS improvement process only for about 2 years. It's a 4-year initiative. We've got about a half a year left, but we had an initial setup phase. And so it's 2 to 2.5 years of results that I'm going to be presenting. We have a number of areas of technical assistance in the Data for Health initiative in order to try to holistically intervene and work in partnership with government to strengthen these systems. We operate under the philosophy of being country-led, of strengthening capacity, both institutional and individual, and laying the groundwork for sustainability. And we also, I should note, have a strong role of contemporary digital technologies to catapult system improvements rapidly into the 21st century. Some country examples now. In Bangladesh, which you'll hear about more, we're scaling improvements to increase registration and cause of death data. We have seen through the development of a local model of civil registration and cause of death ascertainment a 40-fold increase in registration of births and deaths over the time period of intervention. And this scalable model is being replicated now around the country at the sub-district level, including a sub-district for sub-district match of domestic resources that the Bangladesh government is putting in directly to scaling up this model. In Rwanda, as my colleague Yusuf will discuss or allude to, there are causes of death from the community that are now understood for the very first time. We have also assisted to strengthen CRVS governance in Rwanda, and the government has been leading in this process all along. In Peru, we're improving facility causes of death and the availability of those data. Moving to a digital cause of death certification system in health facilities, which has brought the time of availability of cause of death data from 2 years, which it was previously in the manual paper system, down to just 2 weeks. And then finally, in the spirit of leaving no one behind, in the small country of Solomon Islands, we have helped the government to extend national coverage of improved cause of death systems. And we have had the opportunity to train both verbal autopsy enumerators as well as physicians to do proper certification of cause of death. So these are just a handful of examples that illustrate that yes, indeed, change is possible. And then not only is it possible, it's possible with a catalytic investment done in partnership with willing governments who are inspired and motivated to improve their CRVS systems, and done in a time scale that was probably previously thought unrealistic. Here I've just put up some of the success factors and challenges. I know we're pressed for time in this session, and so I won't read through the slide, but I think I would just like to conclude on the note that indeed change is possible, and that we're looking forward to working in partnership and continued partnership with governments to cement, sustain, and institutionalize these changes. Thank you very much.
Philip, thank you very much. I'd like to turn it over to Yusuf to tell us a little bit about the situation in Rwanda.
Yeah, thank you very much. I'm not using any slides because of time. First of all, I would want to reiterate and emphasize that it is possible. It is possible to get good statistics, especially in the health domain, and doing it quickly and affordable and sustainably. Of course, there are so many data needs and data possibilities in the health domain. But in this session, we are focusing, we are narrowing down at least to birth and death information, because that is really basic health information that most countries are lacking, and where it is evident that if done correctly, a lot can be achieved. And if those lessons are transferred to even other areas of health statistics, we could achieve a lot more quickly. Around 2 years ago, we started thinking differently. We started thinking differently 2-3 years ago. We started thinking differently regarding the civil registration. And the reason we started thinking differently is because we thought at the initial pace would never finish. Would spend, just like the saying, all other partners say that civil registration is like too huge to be managed. Another thing is resources and also sustainability. We wanted to fix both birth and death in a period of 3 years. And we thought it was possible to begin with. And now, 3 years down the road, actually we fixed birth. And we've got like 20%, 30% of death. And the only reason we failed to fix death is because we hadn't got resources, very little resources, to scale up. So if we had got those resources to the tune of $1, $2, $3 million US, we could have scaled up, and by now we'd be talking of a different story. Regarding birth, thinking of new technologies, the way new technologies can support in registering birth quickly, we see nowadays most countries have wide coverages of internet. And you don't need to fix the traditional systems of network lines and so on and so forth. You just need to use wireless technologies. We need to use over-the-shelf tools for collecting the information, or even use locally produced tools. For example, the civil registration system that we are using to collect birth registration and actually death registration is a system that university graduates in Rwanda produced at a cost less than $200,000 US. And as we speak, as of now, we are registering around 93% of all births that are taking place in the country, using a system that cost us less than $200,000 US. Regarding death, the main challenge is in death registration. In death, especially cause of death registration. There we had to use some tools that are developed by partners globally. World Health Organization develops those tools, verbal autopsy programs, and we managed to pilot the system in Rwanda and link it to the civil registration, and it actually worked. It actually worked, and now we are at a level of scaling it up. So when we look at the pace that we are moving, and the results that we are getting, it confirms that we can achieve a lot quickly if we think through properly and do the right things in terms of investment in what we need to do. Thank you very much.
Thank you very much for that. I think we'll now move on to Anir, who's going to comment more on what's happening in Bangladesh.
Thank you. We talked about whether change is possible or not, and what we have seen is that change is not only possible, accelerated change is possible. It is also possible to improve policy making, and it is possible to improve service delivery in education, health, financial inclusion, agriculture, law and order, and many other sectors. And we'll see a few examples of that. Let me tell you a couple of stories from Bangladesh. So before I tell the stories, I'll actually jump, because of time, to the conclusion of what we learned from these stories. There is a new data mindset that we have actually been able to install within the government. And there are new data platforms, collaborative platforms, which are not only whole of government, but also increasingly becoming whole of society. And we've seen people solving problems using ICT and not ICT solving problems. ICT is not a panacea. One example from health. For a number of years, we've been using the open source DHIS2 platform. It's apparently the largest implementation of DHIS2 in the world, with about 14,000 community clinics sending data from the field using slow internet connection to the central server every day. So there is data coming in, and policy making is happening in terms of disease surveillance, in terms of prioritization, and all of that by the health department. There is a large community of about 60,000 health workers and family planning workers. About 25,000 of them actually now have access to tablets, and they're using these tablets to send information to the central server. Another example is the Kaliganj model, where Vital Statistics and Bloomberg actually have really helped us with not only strategy development, but also technology development and coordination. The numbers are quite stark. Although we've had a birth and death registration law and about 5,000 centers across the country supporting electronic birth and death registration, we have not really had much conformance. We have a law that says you have to register birth and death within 45 days of the event. And the conformance was about 2.5 to 3%. So when we introduced this Kaliganj model, you can see the numbers went up dramatically. So within 2 years, the birth registration rate went from 1.4% within 45 days to about 95%. Death registration rate went from less than 1% to about 85%. So that's dramatic increase. We did not really expect it. And now we're actually scaling this model up to about 13 sub-districts of the country, spanning about 4 million people. So what really happened here? How did this change really take place? The first, we actually saw that we needed to coordinate at the central level. We need to have the permanent secretaries and the ministers working together. We formed a cabinet committee headed by the head of civil service, the cabinet secretary, and the coordination across data sharing from one department to another actually happens at that level. The decision needed to be taken at that level. But then we also needed to coordinate the local level. So the central decision often doesn't trickle down to the lower level and things don't get implemented. But in this case, we need to actually coordinate the local level where the health workers who go from door to door and know about the birth event collect information and send it to the local registrar. And that was actually quite phenomenal. We had not had this kind of collaboration between these two departments, health and local government, ever before. But that needed to be coordinated as well. Because these are peer-to-peer institutions, they just don't sit together without somebody convening them. And that was the local administration which brought them together and said that this will benefit both sides and this will be a win-win solution, which it did become. And we now are working on data integration. So data from health is actually going to the local government ministry, and this is being expanded to other ministries as well. So we have now convinced the Ministry of Primary Education and the Ministry of Secondary and Post-Secondary Education to bring in their data into this one system. And hopefully we'll have very soon an integrated ID, which we're calling the unique ID, that is tied to the national ID, which is biometrically verified. So the architecture looks sort of like this. I won't go into the details of it, but essentially we're bringing in several very important peer-to-peer ministries facilitated by the cabinet into creation of this one unique ID. So national ID, which is biometrically verified, birth registration system, which is not biometrically verified, are being combined to create this unique ID system. So we have the Election Commission, health, education working together to create this unique ID system. And this will be the basis, the foundation for all service delivery in the future. So what's actually happening here? So we are getting a merged database of IDs, one number, which is 10-digit random number, not the previously coded, geocoded number for every citizen, multiple numbers for every citizen. One central authentication using biometric. Right now for children, we're using tied to the mother and the father's biometric ID. But in future, we're exploring the possibility of child and infant biometric, which may actually ease the process. A set of technical standards that we have published from the cabinet, not from health, not from local government, but from the cabinet, so that everybody abides by these technical standards. And a set of platforms, I talked about the CRVS one, and I'll talk about another one in a second. And a series of data visualization methodologies and platforms. So I think Richard will talk more about that, so I won't go into details of it. So when this is all put in place in the next couple of years, we'll actually have services from across the board, immigration, health, registration of birth and death, law and order, being serviced by this one central database. It's not one database, it's actually a database of databases that connect together. The last story that I want to talk about is something called the Sdg Tracker. When we reported on MDGs, we felt that there were gaps that we did not take into account. So we started early with SDGs, and since 2015, we've been developing this tool, which was launched at the UN General Assembly by our Honorable Prime Minister last year, called the Sdg Tracker. We just signed an MOU with Peru to share our insights and knowledge on the Sdg Tracker. So this allows indicator by indicator reporting, allows comparison across regions, allows comparison over time, allows correlation across indicators. So this actually allows you to create competition across regions and over time. So you excel from your previous state, and you excel compared to your neighbor or any other competitor within political constituency and administrative constituency. So the message that I want to leave behind is that we would, as we talk about not leaving anybody behind in counting, we also don't want to leave anybody behind in services. Thank you very much.
Thank you for that, Anir. That was a really interesting perspective from Bangladesh. I want to keep us moving along so that we'll have an opportunity to have some questions from the audience. And turning to Lola, who's going to give us an NGO perspective. Lola?
Thank you very much. I am from Nigeria, and one of the key things that challenges us is the fragmentation of data for women and children. Can I have the next slide, please? Okay. So I'm presenting to you the Tariro projects. The Tariro projects looks at the current levels of birth registration and death registration in Nigeria. And as of the last time we checked, only 65% of births were registered and 35% overall registration of deaths. This means that there is a lot happening around women and children and a lot of investment around women and children that we were not linking with any administrative data at all. And like you've heard again and again, what you don't count, you don't measure, you don't act on, and you cannot track the accountability of. So as civil society organizations, we found that we could not track accountability for women and children without any data that is integrated. That's one. Two, across sectors, women, especially children, are impacting on education, they're impacting on health, they're impacting on protection, they're impacting on survival. So it was difficult for you to talk about child protection, child survival, or even any early learning facilities without the appropriate data. So what the Tariro project seeks to do is to link vital statistics for women and children with health facility data so that it is tracked and we can demand accountability with communities using data in data visualized format. Our commitment is that no child should be lost or left behind. Again, in Nigeria, we've had a recent number of children who are kind of lost, kidnapped or lost. And so one of the messages we have is that if your child is not registered, if your child has no ID, that child is actually maybe at home, but is lost to the system. And so birth registration and vital statistics become very important. It becomes a value. We're trying to create vital statistics as a value to mothers, as a value to government, and as a value to community. So your child may be at home, but may be lost. Then no child should be denied the basic access to basic needs to survive and thrive. If your child is not registered, then your child has is also lost to planning, lost to education, lost to services, lost to nutrition. And so that is the commitment we have to the people in Lagos. So there are three components: tracking indicators of survival, of health, of nutrition, from pre-conception. I think we've just changed it to pre-conception to 60 months in what we call Tariro cards. Enabling access to early learning, child development, and nutrition centers, so that in your card you also see value of access to services for your child and also as a mother. And then above all, promoting access to, action on, and use of good data by policy, and going beyond that by politicians and also by parliamentarians. At the moment, we do not have enough of data driving policy. We don't have enough of data driving accountability. We don't have a lot of data used by parliamentary legislative purposes. And so with good data that we were collecting through the Tariro cards, we can impact on policy, impact on legislative action for women and children. We are working in 6 states across Nigeria. The most robust state is Lagos State, and there are early indications of work in all the 5 other states who have responded to the progress in Lagos State. This is a Tariro card. There's a political mileage you get by giving a child a Tariro card. And so the Tariro card is linked to the data in the cloud. I'm not a technology person, but they tell me, and we see it, that when you slip in a Tariro card, you can access the information of the woman and the child from preconception to 60 months. This is the data in each Tariro card. It's arranged across 8 clusters, 8 levels. Tariro level 0 is the basic demographic data. Tariro level 1 is pregnancy and preconception, and it goes down to 60 months up to Tariro level 7. They have been arranged into clusters of basic, indicators of survival, indicators of thriving, and indicators of excelling. By age 5, we expect that brain development is completed, and the indicators of excelling shows that cognitive action, cognitive learning is being completed in that child, and the mother and the system has access to the data. This is an early learning facility in Nigeria. We also advocate using this data that 85% of brain development is completed by age 5. No child should be in an early learning facility like this, and that is with 43% of Nigerian children don't attend early learning facilities. Again, we were able to get this data because we were able to link the survival data to thriving and excelling by collecting this data from early learning facilities as well. I think for me, as an advocate, the biggest part of our work is not just collecting the data. Data exists in many African countries, and a lot of data does exist. They exist in forms that are not easy to access, and they are published in forms that don't mean anything to communities. So over time, we don't have a demand for data because we have not created a value for their use. Linked to the Tariro card is a campaign called BIG. B means better use, I means improved action, and G is good data. So while we are advocating from the technical process to produce good data, it should be in accessible form that promotes use. It should also be visualized so that communities can themselves access the data. So in very simple forms, although I don't have the data here, when it's red, a community knows it's bad. When it's green, a community knows it's good. And when it's yellow, the community knows it's maybe. So the data visualized formats help communities to say, we want our reds to go down and our greens to go up. So all the data is produced in simple data visualized form. And we've been very fortunate to have policy support for this. The women leader in Lagos, Honorable Olajumoke Okoya-Thomas, is a champion for data use by policy and legislative processes in a campaign called BIG. I registered. She promotes registration of births in the campaign called I Registered. If I register, my child counts and my child survives. Birth registration, respectful care and birth care, immunization, child health, nutrition, access to learning facilities, and child protection data are included in my Tariro card. My child counts, my child matters, I must register if I have not. And so that links administrative data to vital statistics and to health data across different sectors. I must apologize for this. I cannot even read it myself, but it shows you the milestones we have achieved in this process. We have also we also have technology partners that are increasingly linking this data to administrative data, and we're in consultation with the National and State Bureau of Statistics to ensure that it's also linked to DHIS2 and facility data in an integrated form to protect women and children. That's how women must survive, thrive, and excel, and also not die in the process of giving birth to children. It requires data. This is what the Tariro process brings to Lagos and is extending to 6 other states in Nigeria. Thank you.
Lola, thank you very much for that presentation. That was really interesting, and I think you'll receive lots of questions on that piece. But we're going to move on to our last presenter right now before we take questions. And Richard, would you like to go ahead?
So it's somewhat, I think, of heresy to say at the World Data Forum that we really don't care about data as an end, right? We care about data because the title of this panel is Better Data Systems Toward Better Health. What we care about is health. What we care about are the end results of it, not just the data. Data is not an end, it's a means to an end. And so one of the things that has been one of the centerpieces of the Data for Health Initiative, Bloomberg Data for Health Initiative, has been how do we translate data into policy? We would like to think, let me just see if I'm doing this right. We'd like to think that it's a pretty straight arrow. The data turns into policy. But we know from both our personal experience as well as a lot of research that the link between data and policy is not direct. That it works through a lot of different intermediaries, right? That it is intermediated by processes, it is intermediated by people, and it's intermediated by products. And we're going to talk a little bit about how the Data for Health Initiative, the data impact portion of that, is trying to make each of these components, each of these intermediaries stronger about doing what many of our panelists talked about is using data for decision making and really resulting in better health policies that will have health impacts for the population, which is what we care about. Right? So let's talk about processes first. The one thing that is clear to us as we've worked in, as Kelly had mentioned, we're working in 20 countries, is that you need strong processes and systems to get the right data to the right people with the right insights at the right time. that data by itself doesn't change policy if it doesn't get to the right people. It doesn't change policy if it's not interpretable. It doesn't change policy if it arrives too late. So one of the things that we realized as part of this initiative is that we had to work with governments to improve the processes and systems. And we've done things like doing visualizations of data that Anir had talked about, talking about how we use dashboards and the like. We're doing this in the 20 countries there are, we're working in at least 10 of them, doing 15 different projects that are about things like creating dashboards, redesigning processes, doing new structures. One of the places that we are working in right now is Morocco. In Morocco, we've helped to support a structural change, which is the establishment of 12 regional health observatories, where these, at the regional level, they are collecting data for decision making, all right? We've also worked with them to create tools like dashboards that will visualize this data for decision makers. And we are also implementing improvements to improve the data. And as a result of this, regional leaders are in better position to make decisions about service improvements, better able to see where there might be gaps in services that can be addressed at the regional level. And then as Anir had mentioned before, part of it is about creating this sense of competition, that if you've got regional health observatories, you create this impetus for change. And so we really start to see the foundation for service improvement in Morocco as a result of these procedural and structural changes. So that's one of the intermediaries that we work through in the data impact program. The second intermediary that we work through is through reports. And I think we've all had this experience of being frustrated by data, right? That people spend a lot of time collecting data, and then it's reported in a 300-page report with table after table after table after table after table of those data. And it is making it available. It is making it accessible in a way, but it's really not very usable. And you can't imagine a decision maker sitting there at his or her desk and trying to leaf through all of that, all the reports to find the data that might be important to them. So we've talked about how to make published reports more impactful. And we're also working with countries to facilitate the development of data access portals. Many countries already have them, but many countries, regions, and cities don't. And so we've created tools for making data access portals easier to create. One of the places where this focus on improving reports has really worked out has been in Peru. We're doing it in 15 different places, but I want to talk to you a little bit about Peru. Peru collected a lot of mortality data, but they never really published it in an integrated report. And so there's all this data that is available, but there was no messaging. There was no insight. There was no implication for decision making. By taking that information, putting it in a structured report with a clear message and clear communication aims, and pairing that with online interactive atlas for accessing the data, we have created sort of an environment where those data, rather than sitting on a shelf, are affecting things like prioritization of health department issues, prioritization of funding, and really seeing that there's a change in action that leads to better policy and therefore better health. The final intermediary that we work through is through people. And obviously, right, data doesn't change policy, people change policy. And so we've developed different programs for how people use data in their work. And we really focus on three groups of people. One is senior executive teams, how they interpret data and how they translate data into guidance for decision making. We work with public health analysts about how they process data to produce recommendations and evaluate recommendations for change. And we're also working with journalists in print, radio, and online medias. And we've been doing this we have about 50 different efforts that we've done improving people's capacity to do this. I want to talk to you about two specific things. One is we have a journalist training program where we have worked with over 100 journalists who have done about 130 different stories that use data to talk about a public health issue, and that helps to create the environment for policy change and the demand for more data. And one of our signature programs is that we've got is the data to policy program, where we focus on developing policy briefs that use data to really recommend change. As part of this program, we've developed 75 different policy briefs, and 25 of them have already been advanced in the policymaking process. So we're seeing that there is a route to policy change through data and helping to strengthen these intermediaries. The final thing that I want to talk to you about, and we sort of talk a little bit about people, process, and products, and I talked about them separately, but I think the final lesson that we've learned from the data for health, data impact component of that is that you really need to be doing this all together. And when we're working in places like Bangladesh and in other countries, we're not doing just one of these things. We're usually doing multiple things. This shows you a little bit about, in Brazil, for example, we were working on 4 or 5 different products with them, improving their annual assessment of health, working with them to improve their analysis of the spread of the Zika virus, working with them in terms of infant mortality and those sorts of things, working with them to change processes for how they analyze data and how they spread it through their ministry. And we're working with people, both journalists, leaders, and analysts. And so one of the things we sort of learned is because data to policy goes through intermediaries, all those intermediaries need to be strong if you're really going to see an impact from data to policy. So thank you, and that's it.
So thank you, Rich. I think we've really heard a spectrum of examples, many country examples from the panel, which I think is very encouraging and a lot of positives. So before we take questions from the audience, I think we can give a round of applause to all the presenters. Thank you very much. So we are at a part now where we have a good chunk of time to take questions from the audience. I'm hoping that there is some sort of a microphone somewhere. Yes, we have a person with a microphone and another person with a microphone. So if you have a question, just raise your hand and the panelists would be happy, or myself would be happy to take those questions. It's hard for me to see from here. There's a question right in the front, actually. There you go.
This is Romis from Bangladesh. I work at the A2A program as a head of results management. My question to Research Dilani, he mentioned that, okay, data project in different way, how data can help us to have a bigger picture. But around the data, there are some SDG indicators and also some cluster indicators, like in the maternal mortality and then also maternal child health, there are 19, 20, or 25 indicators. Some are very closely correlated, some are not that much closely correlated. But there are some 25, 26, or more than that, there are some health indicators in the SDG and also the universal health coverage. So, but what we are developing or creating some data initiative at the national level, and around the SDGs, what should be the focus? Is that CRBS? Is that SDGs? Or to have a clear picture around the maternal child health or other health areas? So at the national level, what should be the priority? What do you think?
So you're asking a question about prioritization. I don't, Rich, do you want to talk? Maybe you've encountered that question at country level.
Right. So I think that one of the things that we find about trying to translate data into policy is exactly that question, right? There's lots of things that decision makers get pulled between, right? So if you're a health decision maker, a health policy maker, you've got responsibility for a whole range of things. And so how do you decide what's the priority for what you are doing? And so I think that one of the things that data does, and when we work with countries, is to think about prioritization at national levels, and that's usually done by looking at stronger CRVS data about what's really causing death in a country, for example. But it's also, and I think what you alluded to is that priorities may also be geography, or they might be demographics, right? That you need robust data because infant mortality may not be a national priority, right? It may be a priority in 2 or 3 areas because that's really where it's a problem. And without that type of information about where something's a problem, what ends up happening is decision makers need to make average policy that affects across the board. And we all know that's not either effective or efficient, right? You're underserving some areas and overserving other areas, and it's not a very good way of prioritizing. So I think that one of the things that we work with in countries is that notion of not only thinking about priorities at that national level, but also at the more micro levels, which we think is really important in the process of really delivering programs and policies that improve health.
Lola, did you want to add something to that?
Thank you. I think your priorities at country level should be driven by the burden of disease at the country level. And it's not a competition or a prioritization between should I do CRVS or should I focus on UHC. You would find that many of the indicators of maternal mortality or the promotion of the health of women and children or health on its whole are not located within any one program. Some of the indicators are overlapping. And so WHO has developed what they call the 100 core indicators, which is for health and really covers the broad spectrum of the life continuum of health, from when you are conceived to when you die. And that is something that we are pushing that countries should consider those indicators rather than consider the programs, because those indicators are standard. In addition, the Health Data Collaborative is working on aligning data collection methods, aligning data collection processes and data collection system. This is what we key into in the Tariro projects without creating a competition between or be forced to prioritize between universal health coverage or CRVS. CRVS is foundational administrative data. You can't prioritize it out. Neither can you prioritize coverage by services, nor can you prioritize mortality indicators. And so those standard indicators are included in the Tariro card because they cut across a continuum of care from conception till death.
Great. Are there other questions? There's one right here.
Hi, Bill Anderson from Development Initiatives. I don't know, with Vital Strategies coming in with fresh pairs of eyes, you would agree with me that we have insufficient data because we ask too many questions. If I could give an anecdote from Zimbabwe, where I was working recently, and there was an HIV and AIDS specialist talking about a nurse in a rural clinic who treated a patient and then needed to fill out a form. The form was a yard long, and so she passed the form to an administrative assistant who didn't know the patient and filled in the form badly. And when we asked why was the form so long, they said, well, there were about 10 questions we needed, but we got 3 donors, and they've each got their own questions, and hence there's that much. I heard a comment this morning also in terms of cause of death. Is there room for a simplified system in terms of the number of deaths, types of deaths that need recording? No?
Philip, do you want to start?
Sure, I'll take that to begin with. The data collection burden on frontline, speaking now for the health sector, or about the health sector, which is where my experience is, the data collection burdens on frontline health workers can be staggering. There's no question about it. The consolidation and the rationalization of data collection instruments has been a theme for at least 10 or 15 years. And I hope we're beginning to move in the right direction from the standpoint of really being able to be clear about minimal packages of information needs that are really to be used for insight and decision making. And I'm speaking mostly about administrative data. I'm not speaking about surveys or household surveys and so forth. But you know, it's a very important thing to bear in mind when we try to strengthen systems and when we try to leverage the presence of an interaction between a household and a frontline health worker to capture key precious information such as the fact of a birth or the fact of a death, and if there's a death, the signs and symptoms through the verbal autopsy instrument that can help us determine the likely cause of death. I think the one area where we are actively looking at trying to minimize the data collection burden is in this area of verbal autopsy. And we're working hand in hand as part of the WHO's verbal autopsy working group with them to streamline the existing questionnaire to make it as painless as possible to administer and to reduce the amount of data that we try to collect in the context of a verbal autopsy interview. So that's a smattering of a reply, but I think the point is very well taken, and it's something that really must be borne in mind, particularly as SDG monitoring is going to start to ramp up. So it's a very, very important point.
Yusuf, did you want to add something?
Yeah, I think this is a fundamental question. I'll give you a quick assessment, maybe even beyond a health. The SDGs, we have around 230-something unique indicators. Now, we were involved in dialogue during national planning processes, strategic plan for development in Rwanda. And we had around 1,000 indicators. And it was interesting to me, so I tried to look at the details. What are these 1,000 indicators? So the country has committed to the SDGs, and there are 200 indicators, and we think that's too much. Now, the country has 1,000 indicators. My question is, what is the country going to do that is different from the SDGs? Because if we thought 200 was too much, then 1,000 is impossible. Mm-hmm. Now, to our knowledge, which is not a surprise, actually asks so many things, some of the things that we actually don't need, we don't even have programs for, or we don't have programs at a good enough scale to make a difference. Sometimes we ask the same things differently, and then we duplicate collectors, then we burden the people we ask for information for, then we spend a lot of money, then we spend a lot of time, and finally everything doesn't happen, or everything happens at a very small scale. So it's very important. It's very important that as we go forward, we start thinking about rationalizing what information do we collect. So I think it's a valid question. Thank you.
We've got a question back here.
Okay. Thank you very much for a very good. Is it on?
It's hard to hear. Maybe
okay.
there's.
Is it on now? Yes. Okay.
There
Thank you very much for a very good session. My name is Maarten Oranje from Cordate, an international NGO, and I have a question specifically about the Rwanda case. Because as you were saying, you said that 2-3 years ago you started to think completely differently about this subject, CRVS. And I was wondering whether in some way there was a fertile ground for this, because I know Rwanda has a history of results-based financing in healthcare, of rolling out community-based health insurance, whether somehow there are certain preconditions for you, or there was somehow a fertile ground for actually setting this up, or also in advising other countries, would you say that there are preconditions to get this going? Thank you.
I don't know whether I heard it properly, but I'll try to repeat it so that you advise me if I've not got it right. Are there some preconditions? Are there some preconditions that allow doing it quickly, like especially, let's say, like birth registration? I think some preconditions would help, like incentives, but actually in Rwanda, we haven't started using them. For example, in health insurance and in early education. If you use health in Rwanda, health insurance is universal, and even the poorest of the poorest have health insurance that is sponsored by the government. And to register, to get benefits from the health insurance from the first day of being born, you should at least be registered. Now, that is a very strong incentive, but actually it hasn't started working yet. Fortunately, civil registration is moving faster than we being able to apply that incentive to support civil registration. So yes, incentives in some other countries are very important to, as we think about rolling out these processes, we should also think of the incentives at the same time. But in Rwanda, it wasn't the case. Actually, in Rwanda, that's what we've been discussing. It's mainly about thinking about the processes correctly and engaging properly and prioritizing and avoiding duplication and committing and using local technologies and using resources that we know that are available that we can use.
Another question over here?
Thank you so much for the presentations, excellent presentations. My name is Sana from IDRC in Canada. My question is whether it's worthy to invest in verbal autopsy procedures or to invest more in the ICD training, working with the government on sustainable mechanisms for identifying causes of death. Verbal autopsy, I know in many countries that the only way to reach the rural areas and to get the information is verbal autopsy, but for how long? And what's the strategy? How much time, like the aid would be supporting mechanisms that will not lead to sustainable systems? And what's the strategy within Data for Health on this issue in particular? Thank you.
Philip, do you want to start?
So it's a good question. Verbal autopsy is not a trivial endeavor. It is time-consuming, it is costly, but we're certainly of the philosophy, I think, in the Data for Health initiative, that the cost of ignorance is much higher. In countries where the Data for Health initiative is supporting governments, it can be up to 80 to 90% of deaths that happen outside of health facilities with no possibility of medical certification of cause of death. So no matter how much you put into strengthening the quality of ICD compliant certification of causes of death, you're still looking through a tiny keyhole at the whole picture. The cost effectiveness of applying verbal autopsy is, I think, something that keeps a lot of us up at night. We want to be sure that we're leveraging technology to bring down costs that used to be very exorbitant in terms of running paper systems. We're looking at shortening the time and the cost of interaction. We're beginning to do some operational research into doing verbal autopsy through a telephone interview to save costs of transport and so forth of health workers visiting households and to reduce refusal rates. So we're taking measures to look at ways to streamline the verbal autopsy. In addition, when applied at scale, there's the question of looking at samples rather than universal application of verbal autopsy. If the purpose of the endeavor is to derive a picture of a representative, over time, a representative picture of the causes of death at the community level, it's not necessary to do a verbal autopsy on every out-of-facility death. So there are things that can be done with sampling that bring down the cost and make it a more sustainable endeavor. We believe that we are now on the cusp of beginning to scale and institutionalize the practice of verbal autopsy in the Data for Health initiative. We've demonstrated the feasibility and deliverability, and now we're moving into the scalability. So we're concerned about cost, we're concerned about sustainability, we're concerned about institutional capacity, reliance on donors, reliance on consultants. And we're working hard to ensure that countries can in fact stand on their own and implement mortality surveillance using both ICD methods in health facilities and verbal autopsy methods until something better comes along outside of health facilities.
I think verbal autopsy is very important, and it will continue being important for the next, I think, 15, 20 years, because when we look at developing countries especially, we don't see it being possible for most of the death to be in hospitals, even by then. Health facilities are struggling even to deal with people who are alive. What about those who are dying? I once discussed it with the Minister of Health and say, Yusuf, you know what? I'm focusing on people who have a chance, who still have a chance. I don't want to crowd the health facility with people who are dying or people who are dead. So it was a reality. Actually, it was very difficult. And when you look at our countries, 15%, 20% deaths in health facilities, and we are not seeing that changing anytime soon. But one thing that we should factor in as we develop these systems, there should be a transition. If we're at 20% now, maybe 5 years down the road, 10 years down the road, we should be getting to 40% and 50% so that by the 30th year, we don't start afresh. We don't start afresh with systems to capture death and cause of death properly in health facilities. And that's what the pilot phase that we did in Rwanda is actually doing. The system is merged, so as we move and more deaths take place in hospitals, we should be seeing less death being captured by verbal autopsy.
Lola, did you want to add something?
Just to reiterate that the capacity of systems to capture death by post-mortem does not only lie in data alone, it lies in big investments in healthcare systems, healthcare infrastructure, healthcare facilities, which is outside the purview of just simple data collection or the validity of the autopsy. So the autopsies in most countries are nested within immediate priorities that build towards long-term gains, like Yusuf has very clearly identified. Some countries are also asking for burial licenses that we must obtain before you bury, which would also make sure that the verbal autopsies suffer from less of a recall bias of what's the cause of death. So yes, it's important to build those sustainable systems of post-mortem, but the investments lie outside just simple data alone.
Okay, so I'm actually watching a little clock up here, which is telling me that we're winding down to the end of this session. I just want to take a moment to say a couple of final words and thank all of our panelists very much for their presentations. I think it was a very heartening discussion. I think that it's very clear that countries are leading these efforts, that countries are having lots of success. There were many examples today of that fact, and I think it's also a repeated theme that we want to collect this data in the most effective and comprehensive way, but really using that data is also extremely important. So we always have to think forward about what are we going to be doing with this information that we're concentrating on. So again, thank all of you for coming to our panel, and thanks to our panelists for their great presentations.